Welcome everyone to today's webinar. I am Anuja Vaidya with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We're looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Vic Schmerbeck is the Executive Vice President of Strategy and Business Development for EMERUS Holdings. Vic has more than 20 years of experience in investment banking and specializes in healthcare services and health system marketing. And panelists providing thought leadership on topics including the future of healthcare services and emerging health system markets. Community leader, which is involved with numerous charitable endeavors involving healthcare and at-risk children, including the Salesmanship Club of Dallas, Children's Medical Center of Dallas, and the Rice School of Dallas. Vic, I'll now turn the floor over to you.
Thank you, Anuja. I appreciate the introduction, and thank you everyone for taking time today to listen in and talk about our favorite topic, which is small format or micro hospitals. Topics that we intend to cover today briefly. Really want to answer three questions for the audience. Which is first and foremost, what are micro hospitals? What's going on broadly in the market? And does it make sense in your particular market and situation? Two, if micro hospitals are something of interest as you think about distribution planning throughout your health system or networks and markets that you serve, is it right to have a partner in the delivery of the service and operation of a micro hospital? And then thirdly, we'll talk about EMERUS to a degree as a party to both of those answers. I'll start quickly with a little bit of an introduction to EMERUS. For those of you who do not know EMERUS, EMERUS is a company that's focused solely on the partnership with leading health systems to deliver co-own, manage, and operate micro hospitals throughout markets across the country. The slide that's on your screen today is really a driver and an underpinning to everything we do as a company. We have embraced the slogan of healthcaring as a calling, and it embodies the five principles of our company. It's something we live every day. And in our offices across the country, and certainly in our corporate office where I sit today, we often talk to our clinicians and our corporate staff that if you're not serving a patient, you need to be serving someone who is. The clinical quality that embodies the delivery through our system with the great partners that we have, we take that seriously every day. We live it. We empower our employees and clinicians to live it as well. A little bit about our experience. We have 10 joint venture partnerships throughout the country. I'll show you a map here in just a second. We currently have 21 hospitals in operation. We have over 25 additional facilities, either in construction, about to open, or under development. We have over 130 years of senior experience on our team. We continue to win with our partners in markets we serve, Press Ganey Guardian of Excellence Awards. We've now won that award for 4 consecutive years. If I'm not mistaken, I think each one of our hospitals that has had the opportunity to win the award has won it at least once. We have multiple physicians on our executive team. The company was founded by physicians a number of years ago, and really guide the clinical principles and activities that we perform inside of small format hospitals. We have multiple marketing awards that really come from all the markets we serve. and really core to EMERUS, from a history and where we sit and operate today, is our entire business is built on partnerships. So partnerships with communities, partnerships with our health system partners, partnerships with our employees and clinicians that serve patients across the country. It's something that we're very proud of. It's something that takes a lot of hard work and execution, but we feel like it's a stronghold of our business. A little map. We are incredibly blessed to have great partners across the country, many of which began in Texas, where our roots began, with the likes of Baptist Health System and Baylor Health System and the Scott and White Health System, now merged together to create Baylor Scott and White. We also have an expanding presence outside of Texas, as you can see, with great partners like SCL Health and Dignity Health and the hospital, St. Alphonsus, Integris, and the likes. Our map continues to expand, but we continue to take the same disciplined approach to market entry with great partners in great markets across the country. So why micro-hospitals, and what are micro-hospitals? It's a question that we get asked a lot, as I'm sure everyone can imagine. We started calling these facilities that you see on the screen now micro-hospitals 6 or 7 or 8 years ago, when we really started talking to health systems about filling distribution networks and expanding access gaps in the markets they serve with small hospitals. And we often got comments around, does that mean 50 beds, 75 beds? And we were certainly thinking much smaller, and always with a mind to co-location of other services. So the market today, as the terminology of micro-hospital has expanded, and there's certainly more talk around micro-hospitals today than there were 5+ years ago, the definition of what is or isn't a micro-hospital has also expanded significantly. So as many of you, I'm sure, have seen, there have been CON filings, and there's been other people that have delivered or built facilities like this that now encompass, $100+ million projects, significantly more beds, 25, 30, 50 beds, that are kind of coined as micro-hospitals, for lack of better terms. So what I thought I would do today is spend a little bit of time on how and why we see the micro-hospital activity in the markets we serve, and also talk a little bit about where we see other opportunities, and certainly leave plenty of time at the end for questions. In our world, the two pictures here are our facilities in our Las Vegas, Nevada market, where we're partnered with Dignity Health St. Rose Dominican. They're independently licensed hospitals. 3 of our facilities there have a 2-story design, roughly 40,000 square feet. We do have one that's the top right picture here that's around 60,000 square feet, 3-story delivery. In all cases, the first floor is the micro-hospital, 8 to 10 inpatient beds, a similar number of emergency treatment triage rooms, lab, radiology, pharmacy, CT, X-ray, ultrasound, dietary, and the likes. And in most of our markets, certainly in the Dignity market, the St. Rose Dominican team is co-locating other outpatient and physician clinic and clinical services inside of the hospital, or inside of the facility. So that often includes primary care, almost always includes primary care, co-location of rotating subspecialists, and then from there it really depends on the supply and demand dynamic and the needs analysis around a given neighborhood or trade area. So it could encompass pediatrics, outpatient rehab or PTOT clinics, We have women's clinics in some. We have outpatient imaging. I say we, our health system partner has outpatient imaging. We also more recently have seen an opportunity to partner with our health systems and their physician groups to deliver surgical capabilities into a market, be that an outpatient multi-specialty ambulatory surgery center, an endoscopy suite, or even inpatient, a small number of inpatient bed capacity in certain locations. But the idea at the end of the day is multiple fold. One, to fill access gaps for our health system partners, to deliver a lot of the pre-acute care in a given neighborhood in a place where people work, live, and play, and bring a higher level of service than what you would find from just a retail clinic or an urgent care, while also trying to be the place where they know they can come in a branded setting, be it Dignity, Baylor, SCL, whomever it may be, and get the care they need in the community they reside in. So it's an exciting opportunity in that regard. The other is to fill a network for a given population. In our Baylor Scott and White market in North Texas, Baylor Scott and White has a health plan. So they think about the managed lives and how can we bring a lower cost, more capital efficient and operationally efficient delivery modality to the market that's a piece of the overall puzzle for their health system delivery, without replicating higher cost community hospital and certainly tertiary and quaternary bed capacity. And then the last is by having the short stay inpatient capabilities and a more robust observation capability, you can really redistribute the low level acuity patients out of a big bed tower where it may be a higher cost setting, and redistribute that capacity and that patient experience out into the communities that they serve. So as we think about the long-term strategy for micro-hospitals, I touched on a number of these in the previous slide, but a single point of access across multiple levels of care. So by co-locating primary care, you have routine, both diagnostic, well, and sick visit. And with the emergency room, you have a high acuity, acute episodic business. You also have the ability to maintain those short stay and observation capabilities, and then also leverage that capacity, as we mentioned, to bring other clinical, lower cost outpatient services to a given marketplace. It allows you to differentiate and prepare for population health. One of the initiatives that we often talk to our partners about is how do you get the most out of the fixed asset? Many years ago, as we all know, patients in our communities had limited choice on where to go. Today, there's an abundance of choice. So how can we create a branded healthcare destination point? The last slide, Dignity Health, St. Rose Dominican, neighborhood hospital. How can we create that branded healthcare destination point so that patients in that community know that they can come to that location and they're going to get served in the right place at the right time at the right cost? So that intersection of cost and quality where you get value. So there's some innovative ways that we've gone about pricing and transparency and bundles inside of the emergency room to lower the cost on the real urgent care oriented visits, that can bring real value to the community, not only to the patients, but payers and providers as well. Real focus on clinical quality and patient satisfaction. By putting yourself in a small facility, it creates opportunities and challenges. The opportunities are you get a lot of team building opportunity with your clinical teams. And if you do that right, in our mind, you also get great patient experiences. There is a lot of interaction between that team when you're compressed into 18,000 square feet. The flip side of that in terms of challenges is you really have to reorchestrate the clinical workflow and expectations of your teams in that small format. It's not the same EMR workflow, it's not the same clinical workflow, it's not the same even reporting structure as it relates to a big campus, either inpatient or ED solution. So being very thoughtful about how you can operate in that small format relative to the larger formats that there's a longer degree of history in terms of operational expertise. It allows for us to be a test bed for innovation, as I touched on. Certainly pricing is one that strategically comes to the fold early and often. And then creating capital efficiency. We oftentimes hear from health systems that we talk to as we look at a particular market that, it's a growing area or it's a replacement facility. Don't we need to build something bigger? And it's not to say that bigger is the wrong answer. I think we come at it from a very disciplined and maybe somewhat challenging perspective of talking about, well, what's the need in the market today? And let's fill that need. And if we're all fortunate enough and do a great job for patients, that ultimately our ability to supply is not enough to meet the demand, then we can build another capital efficient facility to fill another access gap. All of this can also play in the outer urban or rural area. We've talked a lot of the conversation I've had so far has been around a suburban marketplace. There's also an opportunity as we see a lot of aged facilities across the country where a smaller, more efficient workflow can be a replacement for an existing infrastructure. That's probably has a little longer tail to it, but there are lots of 60, 65, 70-year-old facilities spread throughout the U.S. that I think we're all aware of that will come a time for either replacement or renovation. Moving on to the continuum of care, it's a visual depiction of a lot of the things we've already talked about. The green line in the pink box, so to speak, is where I think we really feel like the core of the micro hospital is creating that ambulatory pavilion along the continuum. We also believe, as I mentioned, on the yellow line to the left, that you can really leverage the facility both with the co-location of primary care facilities and contract pricing and even bundled pricing in the acute episodic or walk-in business to treat both the high acuity in an emergency room setting and the lower acuity inside of the facility at a cost-efficient basis. And then on the post-acute side, we've had success utilizing some of the inpatient bed capacity around inpatient palliative care and other aspects, as well as co-location of outpatient rehab and certain other pieces. Those are both much more, as mentioned in this slide, on the post-acute side, very localized based on the supply and demand constraints or opportunities in a given marketplace. I get asked questions often around acuity inside of a facility of this type, and particularly around how does it compare to what others are doing in markets across the country with freestanding emergency rooms. And there's not a lot of data out there to support, but as a depiction, we added here, the left-hand column is a community hospital or a hospital-based ED, a bigger hospital-based ED. The middle column is our portfolio, the EMERUS portfolio. So you can see there's a slight skew to 3, a little more 3, a little less 5 in terms of a slight shift of the acuity inside of a smaller format facility, but a significant contrast relative to urgent care. The next slide really talks about the value proposition and really focused on going across the constituents and stakeholders. First is the health system, or who we partner with in this regard, and the provider. Creating access points, filling market gaps is one we've talked about a lot. We think there's significant clinical and quality improvement that comes with that in the small format setting, if executed properly. There's brand promotion throughout the marketplace. In many markets, it reduces overcrowding of existing infrastructure. Not all markets are that way, but many markets we serve, that is the case. And in fact, we have a number of examples where our health system partner was contemplating deploying capital against an expansion of an existing facility, be it inpatient capacity or emergency room capacity. And in lieu of committing the capital to an expansion of an existing campus, we deployed capital into a micro-hospital or multiple micro-hospitals to fill access gaps where you can serve patients in the community they live, but coordinate care across the continuum, where we're still bringing those patients on the tertiary and quaternary level back to that main campus for oncological or cardiac or orthopedic needs, whatever the case may be. We see in this setting, at least in our portfolio, I can't speak to others, but in our portfolio, that coordinated transfer to a higher level of care tends to be in the 7 to 8% range of the walk-in population. So there's a portion of that that gets admitted into our facility at the micro hospital, and a portion of that that goes to the larger campus setting. The much bigger number from an output standpoint is the amount of outpatient referrals that go back into the health system for coordinated care. So we have about 34% in our portfolio of patients that present on the acute episodic side that have post-discharge follow-up orders, be it to a primary care physician, a specialist, lab, whatever it may be. And the idea is we really want to capture that patient into the system, align them with a medical home, preferably our partner's system, but align them with a medical home so that they can be treated at the right place at the right time for their future needs. A lot of that geared around how do you leverage, again, that location and that fixed asset for population health management and value-based care on a go-forward basis. On the payer side, there is a common conversation that happens around payers saying you're adding more points of care, you're adding higher cost care. And I think when we're finished with the conversation, payers begin to understand that we're really driving better outcomes at lower cost. So you are providing, kind of critical clinical access points for patients. On the inpatient side, we've been able to really show lower total cost of care by shorter length of stay for same or common conditions. Lower readmission rates because you're given a little bit longer time to treat that patient and hopefully get that outcome correct. You'll see a little bit later in the slide some of our Medicare core guideline measures around clinical quality and patient satisfaction. We operate in the top 10th percentile of all hospitals in the U.S., and I think all categories and in most we're in the top 5%. So improved outcomes across the continuum. We have been very blessed with great clinicians and physicians in our facilities. We have negligible litigation rates. You can see the physician complaint ratio is really next to zero. We spend a lot of time on employee engagement as a company, really driving happy employees to happy patient outcomes. And then on the patient side, this is probably the easiest one to talk about, frankly. Across our portfolio, patients see on the walk-in side of the business, patients see a board-certified ER physician inside of 10 minutes, and they're discharged inside of 90 minutes. On the highest end of care, where patients present with a STEMI or they're having a heart attack, across our portfolio, our door-to-balloon times are equivalent, if not less, than had that patient walked in the ED of the hospital we transfer to. So reduced wait times, faster discharge times, shorter length of stay, a very compassionate and patient-friendly care model. If you noticed or snapped a picture of the first slide where we talked about our core values, empathy is one of those. It has been from the day we started this company. Empathetic care is something we really drive through our system. One of our founding physicians has often told me, we know we've won an employee and a clinician over when they stop asking, where do you hurt? And they say, how can I help you? So a lot of that goes to the opportunity that is presented inside of a small format hospital. So what do you need to drive a small format hospital operation? And selfishly, what does a partner like EMERUS bring to the table as you think about that, delivering a micro hospital footprint into the markets you serve? These are all the teams that we have dedicated to our partnerships with health systems across the country. From the very beginning around analytics of site selection, understanding the retail component of where a facility should go in an urban setting, and in a rural or replacement setting, really understanding what is out there that you can capture, what are the clinical service lines that can be supported, and what is that community need, how wide's the catchment area, what do you need in terms of facility design and construction to make that work. So from everything from design, clinical workflow, something we pride ourselves on significantly in terms of the efficiency inside the facility. We talk about how do we make sure we get the most out of not only the facility, but the room, in giving great patient care, but also valuing that patient's time, and through workflow for our clinicians, allowing them to be more efficient in their delivery of service. So clinical protocols, quality protocols around the patient and clinical experience, all of the finance and operation aspects of forecasting, budgeting, the business development, both on the front end in terms of where do we locate and why from a distribution planning perspective, but also that continual reassessment of the market and how things are changing in a market. Where do we need to be thinking about for the next location or set of locations, be it new de novo or replacement or renovation. The ability on the IT front and the EMR front to be efficient in the clinical delivery. and I'm going to spend a couple minutes on this one just because it's important to those, whether you partner with someone like EMERUS or you're thinking about doing something on your own. It is a different business from an operational perspective. So thinking about not only the workflows from a, design in the facility in terms of number of steps and where's the lab and where's infection control and where's the pharmacy and those kind of things, to also the clinical workflow inside of the EMR, and can you task that smaller team in a smaller setting to deliver the same throughput while maintaining those EMR and integrated patient records. So lots of experience on our end there, and it's one that if you're thinking about it, it's something that can be very beneficial and also can be very cumbersome to the ultimate delivery. Marketing, understanding the more local marketing aspects of the ring around a particular location. How do you get to those patients so that they understand the value of the facility? And then overall HR and operations in terms of understanding the types of employees that thrive and succeed in a small format structure versus those that don't. And operationally, how do you properly staff, swing shift, cross-train to maintain efficiency inside of the facility operations. As it relates to the front end piece of that on the development, and I won't spend too much more time, I want to leave time for questions, but we think it's important when you step back and are first analyzing what are the opportunities, that you first have to look at the market at large to determine how is your distribution, how's your network design, what services are there. When we're going through this with our health system partners, we're not just looking at the componentry of the micro hospital, meaning the acute episodic and the short stay inpatient needs, but we're also looking at their existing footprint, not only of their community and tertiary hospitals, but also their physician clinics and urgent care and retail clinic and other imaging, surgery, other elements of their delivery system, to really think about how do you get the most out of a location without replicating fixed assets in a given trade area. And then honing down from there to very specific site selection within a given market, a trade area site selection, making sure that you understand visibility, access, traffic counts, and things of that nature that are important to the community that you serve. The next slide really talks about, and I won't spend too much time on this, but it's important to understand the households that you're serving. I think we've all gotten smarter in this regard over time, but that geointelligence around who is in that household, how do they get served, how do they get their healthcare needs served, what can we as the healthcare continuum do a better job of in terms of bringing that value to that household, to that population in a given area. So in order to do that, you really have to understand the market level dynamics, that both primary and secondary, to really factor into the overall site selection componentry and ultimately the network strategy and distribution planning. But understanding who and why who utilizes small format facilities, why they utilize small format facilities, and what are they really gaining from that is critical to the overall distribution strategy. We get a lot of questions in this regard as it relates to, well, what about a freestanding emergency room versus a micro hospital? There are unique circumstances in any given market. Healthcare is very local, that both can be successful for a system. We have chosen, for better or worse, to focus more on a micro-hospital strategy for a lot of the reasons we talked about earlier, being able to maintain observation, having short stay inpatient needs, really keeping that lower acuity inpatient out of a bigger campus, both for patient satisfaction, overall and total cost of care, as well as patient experience and convenience. Oops. I touched on this a little bit earlier, but just a quick visual. I won't read through all these in terms of Medicare core guidelines, both patient satisfaction and others. But you can see, at least in our portfolio inside the micro-hospital, if executed properly, your ability to exceed national averages by meaningful amounts is real. It can be done. In our emergency room setting, we are 90+% on patient satisfaction, likelihood to recommend. On the inpatient side of our setting, somebody can correct me if I'm wrong, but I think we're 98 or 99%. It's a very high number, which all goes to the patient experience and the Guardian of Excellence awards that we've won over and over. I think the same can be done in a rural setting. We have not, at this point, embarked on a purely rural strategy. And a lot of the same discipline and questions as it relates to maybe a little less on site selection in an urban or suburban marketplace, and more around what are the clinical services, what's the population draw area, what's the makeup of that population, household, and draw area, to really think about the operational efficiency and, frankly, the return as it relates to the investment made in a replacement facility in a given market. We do think there's opportunity longer term, as mentioned before. Each market's going to have unique circumstances. I think our belief is it'll be primarily replacement facilities for existing larger infrastructure. And again, not in all cases, but we believe in many it'll be more efficient to replace rather than renovate, just given the operational efficiency that comes from the workflow and design. So we're very proud. We feel, at least in our world, in terms of micro-hospitals and how we're approaching the market, we've really established ourselves as being a partner of choice. We have a lot of lessons learned that go with that. And I think one of the biggest intangible values I would urge everyone to consider as you think about this, if you are thinking about this as strategically in the markets you serve. I know that hospitals, for everybody, many people on the phone, I'm sure, are core to your operations. I think operating a small format, 18, 20, 25,000 square foot facility that may be 8 to 15 beds is a different experience from an operational perspective than a big hospital. So be very diligent as you think about how the workflow can work inside of that facility, the cost parameters that go into it, and frankly, I don't really know another word to say this, but the scope creep that comes from the embedded teams that have, for a long period of time, and I hope nobody takes this the wrong way, for a long period of time have thought bigger. So the scope creep around a location that maybe could be 35 or 40,000 square feet becoming 100 or 150,000 square feet. And instead of having 8 or 10 beds, maybe it's 25. And instead of having 8 or 10 ER bays, it's 24. Really doing the needs analysis around why and the discipline that comes from that. So with that, I'll stop and take questions.
Thank you, Vic. Fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into the control panel in the space labeled Enter a Question for Staff and clicking Send. We will try and get through as many questions as we have time for. So our first question here is, please explain how micro hospitals will compete with or complement ambulatory surgery centers.
Good question. I think it's less competition and more complementary. As I mentioned in my prepared remarks, we're now seeing more of our health systems think about co-location of surgical capabilities, typically not in all facilities, but in certain locations. Where we see it most is where there's a share expansion play. And one thing I didn't talk about here is you think about the distribution network in your given market, and you think about filling those access gaps. Some of those are going to be offensive and some of those are going to be defensive. The defensive would be the example of, rather than deploying capital into an expansion of my existing hospital, I build a micro hospital to fill an access point and deploy capital and intentionally decompress my existing facility so that I don't have to deploy capital for expansion on the existing main campus. The other would be an offensive where you're going outside of maybe your core catchment area to a growing or new area. That's where we see some of our partners really thinking about, okay, if I have inpatient bed capacity and I have primary care and I have an emergency room, should I also be thinking about an outpatient surgical facility, or maybe even a combination of an ASC and a small amount of inpatient surgical to bring more services into that marketplace? But as it relates to, at least in our world in micro hospitals, we're not necessarily trying to compete with the existing surgical capacity that's in a given market. We're really trying to complement it.
Okay, fantastic answer. Our next question is, you said these micro hospitals are individually licensed, but do your partners own them or does EMERUS?
In our case, we create a business with our partner that we co-own, and that entity, NewCo for lack of better terms, owns the hospitals or controls the hospitals. Whether we own the real estate or we lease the real estate, I think is less relevant. But the Medicare provider number, the CCN, the state license is all part of the joint venture.
Okay, fantastic. So how does the workflow differ in this setting? And give any examples?
Does the workflow define the setting?
Sorry, differ in the setting. In this setting.
So from a clinical workflow standpoint, at least in our facilities, and we could share some pictures offline if someone was interested, but it's really a horseshoe in the sense that shared services in the middle, emergency treatment down one wing, inpatient down another wing. In some of our facilities, we also have a fast track or vertical treatment provision in some of our higher volume locations. But really trying to create shared services in the middle and points of entry and access to rooms such that patients have a great experience, and we can be efficient with the utilization of clinicians and supplies. The other piece of it, a lot of the collection. So what you would think of, and I'm thinking more on the ED side of our business, when we're doing H&Ps or history and physicals, or our clinicians are, as a patient walks in, we've set the facility where they can get weight, height, lab, blood, urine before a patient potentially even gets in a room, so that you're really doing an H&P, you're gathering the necessary information that a clinician may need. And by the time that patient gets into a room, we may have a lab test back on a urine sample by the time the patient's sitting in the room and the physician's finished with the H&P. So now you're focused on what's the next clinical decision to be made rather than waiting for test results.
Got it. Very interesting. Our next question is, do you have any examples of projects in a market that is contracting and can no longer support a large hospital, say 300 to 400 beds, and as such, a transition to a micro hospital of maybe up to 50 beds makes more sense?
Yeah, we do. I would say at least in our example, both the first and the last number we're seeing them be a little bit smaller. So we have three replacement facilities today, but they tend to be replacing more like 100-bed hospitals. So would be more of a community hospital that the market maybe has either shifted away from, or our partner has built a newer and in many cases smaller facility somewhere adjacent, or they've consolidated services from 2 hospitals to 1, but you fill the facility that's being that is, in many cases, it's 65-year-old infrastructure. So you're replacing it with a new micro hospital and consolidating your high-end care services into a separate location. I don't know from a market perspective, we haven't seen, and I could be wrong here, but we have not seen many 300 or 400 bed facilities closed down for a 50-bed. I don't know who asked the question. I think you have to be really intentional when you get down to a certain number of beds. 50 may be enough. At least the analysis that we've done, and this is not to say it's in every market, but the analysis that we have done suggests that you can get yourself in an in-between state where you can be too big to really be efficient and not be big enough to bring high-end clinical services to a market. 50 beds may be a threshold you can, but it seems more challenging to us when you get in that 20 to 30 bed range, where you have to be really intentional about how you're going to fill those beds in a given market and what the need is.
Okay, got it. So our next question is a rather long question. So Vic, if you need me to repeat any part of it, do let me know. The question is the micro hospital licensed as an acute care hospital by the state? Do they have an acute care hospital provider number or a CCN through Medicare? Do they bill both Part A and Part B for services provided? And finally, how might site-neutral payments affect the revenue model?
Lots of questions there, but should be pretty easy. They're all licensed hospitals by the state. Each state has a little bit different naming convention. So you could be a specialty hospital in one, or a special hospital in another, or a general hospital in another. But they are all licensed hospitals in the markets we serve. They do have separate CCNs in markets where we have multiple facilities, like Dallas-Fort Worth with Baylor Scott & White. We'll open our 8th location in that market. With Baptist Health System, we opened our 6th and 7th in Q4 of last year. Many states allow you to have a multi-campus license, so every facility may not have a separate CCN, but they all have a Medicare provider number. And then as it relates to site-neutral payments, it's an interesting question, and it's one that we're getting more discussion around today. Site-neutral payments, as they changed 15, 18 months ago, have no effect on your ability to have a micro hospital or a small licensed hospital. What I think we're hearing other people talk about is whether building a small hospital allows them to have maintain hospital-based rates for certain things. If you wanted to have surgery or imaging or other things at hospital rates, building it into the small format hospital, licensed hospital. So I suspect we'll hear more about that as we go forward. Most of our partners, to be real honest, are thinking about kind of lowering cost, not trying to necessarily maintain hospital-based cost in an outpatient setting. So, you know, we're talking to our partners at least, and again, not saying it's right or wrong, but where we are talking to our partners, it typically is about ambulatory surgery settings, not inpatient surgery settings.
Okay, fantastic. So our next question is, what are the key pillars of your finance strategy with JVs, given EMERUS's unique structure, what I imagine to be multiple fiscal years, minority equity, and more?
Yeah, so a little construct of JVs. We typically, well, as I mentioned, we co-own the joint ventures with our partners. They tend to be roughly equal. Ownership percentages for our not-for-profit health system partners. You know, we go through all the maintenance of IRS tax exempt status from a control provision perspective. We're relatively agnostic in terms of a financial reporting perspective, whether we consolidate or use equity method reporting from a financial reporting perspective. Most of our health system partners consolidate the financial results, which then means we have to operate on multiple. We have to operate our joint venture businesses at multiple fiscal year ends. And it's just the nature of the business that we're in, frankly. And we have a team that, as I mentioned on one of the very first slides, our business is really built on partnerships. So there are certain aspects like that, and a few others that, you know, are just part of being a good partner.
Okay, great. So our next question is, are micro hospitals typically established in rural areas, or can they be placed in urban locations?
Both is the short answer. Our portfolio today tends to be a suburban, outer urban portfolio with primarily larger markets. So Dallas, Fort Worth, San Antonio, Denver, Las Vegas, Boise, Oklahoma City, and the likes. But we've talked a fair amount about the rural piece. I do believe there's a rural strategy here, and as much of the either critical access or small facilities in rural areas kind of continue to have aging plant and clinical service and recruitment issues, I think you'll see more movement of small format or micro facilities into the rural setting. It's not there today, but I would suspect it will be there in time.
Okay, great. So our next question is, from an outpatient reimbursement perspective, are you negotiating rates with commercial payers that are lower than hospital rates, but higher than a physician practice or an ambulatory center? And this audience member asked that you might use imaging or surgery as an example.
Yeah, it's a great question, and the answer is it varies based on our health system partner and the market that we serve. So we are a part of our health system partners' managed care strategy. As you saw from the pictures that were in the presentation, all of our facilities, the very first cover is one of our Baylor facilities in Dallas, Fort Worth. We showed you a couple of the Dignity St. Rose Dominican facilities, but all of our facilities are branded our health system partner. They own the business with us. It's part of their network and their care continuum, and we're part of their managed care strategy. So can you choose to price differentiate? You can. They're separately licensed facilities, and we have in certain markets. We have not in all markets. It's a great question, though. We think there's, as I mentioned, we think there's very long-term strategic value to having this format of a facility inside of the distribution network for population health and value-based care. We think you can do some unique things both on the walk-in and acute episodic, as I mentioned, where you can really, through contract pricing, price, according to the level of service and the need. You certainly have the clinical ability to deal with lower end acuity patients, by virtue of board certified ER physicians and ER trained nurse and clinical staff. The issue has always been price. If you go to the emergency room with a level 1 or a level 1 or level 2 visit, you get charged more than you could or would had you gone somewhere else. We think there's ways to fix that through contracting over the long term.
Okay, fantastic. So it looks like this is the last question that we have time for. The question is, what does the management structure or C-suite and organization chart look like to efficiently run a micro hospital?
I'm looking for the question. Do you mind repeating it? I caught pieces of it. I'm sorry.
Oh, sure. No problem. The question was, what does the management structure, C-suite, and organizational chart look like for a micro hospital?
Oh, okay. Thank you.
Sure.
So from our perspective, I think there's two pieces to this, two layers to the overall organizational infrastructure. One is at the facility level, where we have a pretty core staffing team. It's led by a hospital administrator, HA. Core staffing includes a front office or front office manager, physician, nurse, techs, and nurses both obviously on the ED and the inpatient side, and a hospitalist. At least on the facilities that we manage, we have a very prescriptive approach to staffing in terms of what are the staff shifts, how do we swing shift based on volume expectations in given times on the acute episodic side, and on the inpatient side, we'll leverage the hospitalist with APPs and nurse staff. So the core staffing is kind of fixed, and then you swing shift or augment staff based on the volume in a given location and facilities, and we're very active in the management of that. In markets, which is most of our scenarios, where we have multiple facilities, we also have a market level infrastructure that crosses multiple facilities that would encompass, things like pharmacy and infection control and quality managers and CNO and even a CEO. So a lot of it depends on the depth and size scale that you have in a market. So Dallas-Fort Worth, where we have 8 locations, we have a pretty robust market level infrastructure to manage that business. In a market where we may only have 3 locations, then you're looking, how do I create efficiency through the next layer up of a regional infrastructure, or even shared services from our partner. The goal for us is what's the best interest in terms of value to the joint venture in the long run. And by the way, I know you mentioned, I see there's a number of other questions. if people want to email questions, or if the Becker's team wants to email those to us, we'll be happy to try to answer those for those that did not get answered.
Fantastic. Yes, absolutely. That is unfortunately all the time that we have for today. I want to thank Vic for his excellent presentation and to our audience for participating today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.